monthly basis. Each month, one hospital will present few cases, but today we are really very happy and pleased to have you also today. We wish that we have you physically, but I know there was some sort of conditions that prevent you from coming to Saudi Arabia.
Right.
Again, we know that Dr. Alan Barkun from Medina University is a well-known speaker. He has really put a lot of guidelines in upper GI bleeding. And today he's going to share with us his experience and his thoughts with regard to artificial intelligence in GI. Professor, the mic is yours.
Very much. Good evening, everyone. I'm really sorry I cannot be physically with you in Riyadh this evening. And I apologize for that. It was beyond my control, unfortunately. But I am happy to be with you by Zoom. And I'm happy to be talking to you tonight at the invitation of the SGA. And I particularly would like to thank the organizing committee for tonight's meeting, as well as the technical support team, and in particular, Professor Majid Al-Madi for the invitation. So I've been asked to talk to you about artificial intelligence in GI endoscopy. It's a very broad field, one that I'm only partially familiar with at this point in time, but I'm happy to share with you my understanding of the field, and perhaps we can both learn from each other as we go through tonight. So with the objectives at the end of the presentation, I'm hoping that we'll all be able to understand some of the basic concepts but especially terminology of the artificial intelligence world, appreciate some of the regulatory, ethical, and methodological considerations that may limit their timely diffusion or affect the interpretability of the results of these studies that you'll see. In addition, list some of the recent artificial intelligence applications that have been reported in digestive endoscopy and what their performances bring to clinical practice. So let's first start with some terminology. So what is intelligence? Maybe we have to start with that. Intelligence is the mental ability of an agent to reason, plan, solve problems, think abstractly, comprehend complex ideas, and learn from experience. Not included in this is emotion, empathy, moral reasoning, consciousness, or self-awareness, as those are uniquely human. But intelligence itself can be independent of the human component by definition. So we don't expect the machines to be able to do everything, but perhaps rather to improve the way that we do the component of the intelligence component by automating parts of it. And that's what we're going to explore this evening. So what is artificial intelligence? AI is a complex umbrella term for anything related to software-driven automation and complex algorithms. AI, in its true definition, is the concept that machines develop human-like intelligence so they can act independently of humans and can replace and perform tasks that normally require complex human intelligence and reasoning. AI is a machine that can act as smart as a human, in theory. Essentially, AI is a series of predictions based on patterns and other factors used to train a given algorithm, and this will become very important when we look at how we can use it in GI endoscopy. Now, you may hear about the term augmented intelligence. Most of the AI we see today is actually augmented intelligence. And these are algorithms that support the work of humans with additional insight. And you may have heard about this, the human in the loop intelligence, meaning they're provided as a tool to a human to expand the ability of that person to do the work they're doing. So in other words, augmented intelligence is when an algorithm is set to add input from a human in order to create a recommendation. So an algorithm produces an output, a clinician uses all of the clinical info to make a final decision on that output and how it proceeds with regards to handling the patient. And that final decision is fed back to the machine so it can actually learn from it. So the bottom line is that the definitions vary tremendously, and it's best to verify which kind of intelligence is being referred to. Essentially, all AI in the realm of medicine is at present time actually augmented AI. No true general AI exists at the time of this presentation. So what can AI do for us and how? So you see here the reality and perhaps the perception. The perception is what you see in the top cartoon, where there's data and somehow through some magic, the artificial intelligence solution provides insight. But in fact, how you go from point A to point B, highlighted by the red arrow, is actually data that drives a set of probabilities. And we'll look at how those are handled in a very brief way, providing then the final output or insight. So why is AI relevant to clinicians? Well, AI is the newest wave of precipitous change in medical practice, the biggest wave since the rise of evidence-based medicine that occurred in the 1990s. And AI-based technologies have demonstrated successes in many domains of clinical practice, and it makes sense. Look at the areas: decision support systems, diagnosis and prediction, image recognition, and natural language processing, which I'll explain to you a little bit later on if you're not familiar with that term as well. These are all components of what we do routinely in clinical practice, and AI can amplify and allow us to do a better job more quickly, more efficiently. So here you have a Venn diagram of machine intelligence component and the human role within the context of taking decisions and so on. So the overall arching theme is artificial intelligence. Within that, you have machine learning. We are going to talk about machine learning today. And in addition to that, about deep learning, which is a subgroup of machine learning. And most of the data that you may have seen related to endoscopy and polyp detection and characterization and so on relates to the so-called deep learning. I'll explain to you what that is. This interacts with the augmented intelligence, where the AI solution is provided to a human who also bases the decisions on data science as well. So these are the components, if you will, that go into creating some of the tools I'll show you today. So what is machine learning? That's the application of sets of algorithms to analyze a given situation with the ability to learn from feedback about the outcome of the analysis in order to self-adjust and improve accuracy. So through the algorithms you predict, and then the machine can actually learn from it as well. And the greatest benefit of machine learning is its ability to learn from its experience and to improve its own performance. And this is absolutely key. You'll have to keep that in mind as well. When you buy a machine, the machine is a dynamic a tool which may learn based on the information it derives when you're using it. So the different types of machine learning, I don't want to spend too much time on this slide, it's very detailed, but of machine learning, you'll hear about unsupervised learning and supervised learning. Those are the two we'll discuss today. We won't discuss reinforcement learning, which is not as commonly used for what we're looking at today. So if we talk about supervised learning, this is the most hands-on approach to machine learning. The designer provides the program with the data set and the expected result, the outcome, if you will. And the goal is to teach the algorithm to take characteristics from the data set to build a model to use those characteristics to predict things about data that have not yet been seen. That is supervised learning. Unsupervised learning is where the program is provided with a data set, but without any information of what that data set means. The program itself has to figure out links, has to figure out associations, and has to look at potential outputs that can actually work with the data that it's provided with. So the program itself figures out which patterns exit the system and provide output. And of course, it'll do this by clustering data, creating associations within the different types of data. So this leads us to deep learning. Now we build on the sophistication of the machine learning to get to the next generation level. If you remember in the Venn diagram that was within machine learning, the smaller circle was that of deep learning. So deep learning takes algorithms that can do what machine learning does, and then layers them to create artificial neural networks. This is inspired by our own anatomy, neurophysiology, neuroanatomy. And deep learning can learn and make intelligent decisions on its own, and in essence creates its own approach that can be unintelligible to humans, leading to the concept as AI is a black box. So it can be extremely sophisticated and sometimes will come out with output, and the people who have programmed the whole thing won't know why. So it's absolutely key to be able to keep track of what is being done. If not, you get to this so-called black box situation. So what are convoluted neural networks? It was the context of this approach. So you'll see, for example, on the left-hand side is the picture of a bird. You'll show many, many, many different pictures to the AI system of this bird. It'll recognize a number of different characteristics, the color, the shape, maybe the texture, the perceived texture of some of the wings and so on. And eventually the fully connected layers will provide an output, in this case to choose whether the system thinks it's actually seeing a bird or not. So the types of deep learning applications with all these different layers relate to natural language processing, and I'll talk about that in a second, as well as computer vision or machine vision. And obviously I'll talk about that as well for you. These are the two final areas where we then proceed to understand what's been done with regards to AI products at this point in time in GI endoscopy. So the first is natural language processing in action. So on the left-hand side, the actual AI system goes into different types of databases. It could be the EMR of the hospital. It could be the emergency room as well as the hospitalized patient EMR. It may go into the radiology packs. It may go into the pathology system as well. And then it maps all of these different possibilities and is taught gradually, or teaches itself, depending on what's approached, to be linked to provide a concept, a conceptual ID. So for example, a diagnosis, and that'll be the output. And all of this is done through the machine learning tool speaking to the different sources of data once it's been trained to do so. Computer vision is very similar, except in this case, it's not the natural language processing that looks at established either longhand written or computer written notes, but it actually looks at pictures. So you'll provide it with pictures and eventually tell it what it's supposed to understand, to see, and it will develop a number of associations with levels of analysis that we don't always completely comprehend. And that's where some of the difficulty comes in. And eventually, through these different layers, eventually it can actually manage to detect, in this case, polyps. So with that in mind, we've gone through a lot of different definitions: AI, augmented AI, look at deep machine learning, deep learning, natural language processing, and computer vision, machine vision. Now we'll absolutely go through GI. So why is GI actually a very good field? And why have already a number of AI solutions been developed at this point? Well, that's because GI is actually very well positioned to benefit from AI innovation, especially when it comes to endoscopy, because it's image driven, much like radiology. A lot of research has been done in radiology since it's so image driven. So for example, AI can address the issue of human operator dependence and variable performance between endoscopists to address such things such as missed polyps or lesion characterization, which we'll go into, and I'll review with you some of the data that's been published in the GI literature on this. Prospective studies are now being done to show AI effects on improvement in endoscopic performance. That's the next step. First is to see whether we can actually find more polyps or not, but obviously you then want to see whether there's actual overall endoscopic performance or not. Clinical reasoning at its core is a cognitive process of probabilistic decision-making under conditions of uncertainty. It's what we all do every day. You have a pre-test probability and a post-test probability without ever having a definite. It's always a certain level of uncertainty. Whereas earlier machines could not handle such uncertainty, the newer ones can, and this is why we proceed with the models being uncertain outcomes. So how does AI deal with uncertainties? Well, through machine learning, there's an algorithm that finds patterns in large data sets, makes inferences using statistical analyses to express the likelihood of a relationship between the variables that it's detecting and the output, providing you with a best guess, which is actually exactly what we do in daily clinical decision-making. And this is why it's particularly helpful, and add to the visual component of endoscopy, and understand even more why AI would be useful in this case. But a lot of things can go wrong with AI. So let me just share a couple of things with you and a couple of considerations that you may or may not be familiar with. I'm not going to spend a huge time on them, just to mention them. First are ethical issues. Real-world implementation of AI is complex, generates key ethical and regulatory issues. I'm not going to go into detail today, but in any innovation, there's potential for good, but also potential for harm. So there are key issues of data management and medical legal responsibility. And if you have questions, as best I could, I'll try and answer them for you. Then there are issues of data privacy. Who has access to patient data? What is it being used for? Who is using it? Is it being used for secondary purposes, such as for insurance companies, employers? Are the data truly anonymous? If we have time, I'll explain to you why there's actually very little anonymity if you have a lot of information there. It is being commercialized and sold as a commodity or not? What happens if there's data breach? What about informed consent for the patients? If you're using, for example, a polyp detection AI tool, do you have to tell the patients before you start the colonoscopy? Data ownership is a complex ethical issue with multiple stakeholders. How are the data to be shared between AI developers? What about the financial benefits? What mechanisms will maintain the data set and data ecosystem and their intactness and the privacy? So these are huge issues of privacy. Then, of course, you have patient safety and accountability. The goal is, of course, to use safer and better quality care using AI, working in synergy with humans. However, algorithms don't take such considerations into context. And who is responsible for the AI output? If there's a mistake, what if you incorrectly use CAD-X and say that there's not a neoplasm in that little polyp, and in fact there is, and so on and so forth? AI is not infallible. It's not 100%. So all these issues need to be sorted out, and there's huge components of issues right now. Finally, transparency. I've alluded to it with you a little bit before. AI is a black box. Methods and data should be transparent, and so should the interpretation of decisions or outcomes reached by AI. But this is not always as simple, and it's a trade-off. The deep learning models make their own adjustments, and the many layers incorporated into decision-making make it very difficult to follow and interpret how these algorithms are arrived at. So it's a trade-off between the very complex deep neural models that you cannot completely follow and understand what they're using for their sophisticated outputs versus more simple models, which are more interpretable and are less, but however, are less complex. So that's a trade-off that you see throughout the different AI solutions available. And finally, there are rules and regulations. I'm not familiar with them in Saudi Arabia, but there are a huge number of them in North America, Europe, elsewhere. So you would need to be aware of that when you try and purchase a solution. So putting this all together, how are the AI solutions scientifically developed? So you need a gold standard. That is the outcome. And it can be based on histology or multiple expert annotations of images, for example, or using different reports. Choice of performance metrics and their motivation, approach for the validation and testing, and finally, involving hyperparameters, which is a fancy word, which are the variables used for the neural networks and as you develop the AI tool based on this neural network methodology. So this provides you a little bit of the kind of different components used when you actually try and use AI. And I'll just give you some key buzzwords. If you are going to read the literature on this, you need to at least have an idea of them. So you have here the AI validation and implementation. And you can see that from the data will be used to develop the AI tool. You first have a training set all the way to the left that used to train the model. Then the validation that's used for fine-tuning the components of the model, which are the hyperparameters. And eventually, then you move on to a separate data set, which is a test set in which you actually evaluate the model performance. So you proceed for going ahead and getting the data, train the model, validate it, do this many, many different times as you develop further the performance of the model, as you identify more performant hyperparameters, and eventually you move on and go ahead and test it in the test data. And finally, based on that, you get the performance of your AI tool. And all that you read is based on this general structure when you go ahead and look at publications. So with this in mind, let's look at a few examples of AI solutions published in the GI world. First one that you're all familiar with, clearly, this is the performance of artificial intelligence in colonoscopy with adenoma and polyp detection. It's referred to as CAD-E, so CAD for detection. This is a systematic review meta-analysis, 5 studies by Hassan and colleagues who've done a huge amount of work in this area, over 4,000 patients, and they found that the pooled ADR was significantly higher in the CAD-E group than in the control group that did colonoscopy without having the AI technology. So you could see the risk ratio increased by about 44%, very significant. Importantly, the adenoma per colonoscopy average also increased, in this case, by 70% as well. So the APC was higher for 5mm polyps, for 6 to 9mm polyps, but I highlighted as well, the actual adenoma per colonoscopy rate was higher for 10mm adenomas. So it's not just the small polyps it finds the bigger polyps, and it finds them on the right side. These are areas that are absolutely key because we know that this is where the ADR is affected and is weakened with some individuals. With regards to histology, the CAD-E resulted in higher sessile-serrated lesion diagnosis, so it's actually better for the SSRs and the SSLs. And if you actually have used it, you understand it. It really is very good at picking up very flat polyps. And at the end of the day, the benefits that this AI solution, the polyp detection solution, the CAD-E solution provides is independent from the main adenoma characteristic, which suggests that they will have definite impact on patients' improvements and hopefully decrease colon cancer miss rates. This is another meta-analysis on the same topic that included a few more studies and actually did a sequential analysis. The only reason I want to mention this to you is that the only condition in which, or the types of polyps where AI is outperformed by the routine colonoscopy as we now do it, was in pedunculated polyps. Interestingly, the withdrawal times and all the other metrics were similar between both groups. And the trial sequential analysis is a method in meta-analysis where you want to make sure that you don't have a false positive result of a meta-analysis, and you also have sufficient sample size to say that you confidently can say what you say, and this was fulfilled. So the final analysis of the CADI technologies saying that they improve everything I've mentioned to you is correct. With regards to endocytoscopy, this is where you interrogate the actual histology of a lesion. It's called CAD-X because the X is the question mark. What type of histology are we talking about? There's a couple of publications, not as many. Here, it's not as obvious that it's reached prime time at this point. This particular study, 3 pathological class predictions, cancer, adenoma, and non-neoplastic, based on 500 images, 50 images of greater than 20 millimeter lesions that each had 10 images brought to the data set that was used to develop the AI. So already you can see it's not as broad. It tested overall 30 cancers, 15 adenomas, 5 non-neoplastic lesions. You can see very much smaller numbers. And the AI tool was able to analyze not all, but about 20-25% of all the images, which is another limitation. The big advantage here appears to be its specificity. So if you interrogate with an AI solution a given lesion, you actually find that specificity is 97%, meaning that there are 97% of the patients who did not have cancer who did not have these particular findings that were suggestive of cancer, which is very helpful and in the context that we're using it. When you're asking, you're not trying to detect a lesion, you're trying to exclude cancer within an existing lesion. An additional CADEX study was done, this time looking at approximately 234 polyps that were rated by the AI solution, and the gold standard was the six endoscopists, 3 expert and 3 non-expert, who actually went ahead and also rated the likelihood that this was a tumor or neoplastic or non-neoplastic lesion. And unfortunately, or fortunately, in this case here, the CADEX showed non-significant differences between the experts and the AI tool. And the only difference was in a lower specificity for the non-experts compared to the AI. So it's not as obvious a slam dunk in this case compared to the actual detection of polyps. And that's as much as we have right now in this area. So I'm not sure characterization is ready for prime time, although it has been approved and it's used in certain countries. It's in North America, it has not, whereas the polyp detection has at this point. But beware, there's some operational issues as well. So when you use the AI platform, if you've used it, you'll know this. It takes a little while to get used to it because you have green squares or squares that light up around possible polyps. And how long does it take you to get used to this constant buzzing and so on? Well, it's suggested about 10 colonoscopies. It includes also acoustic features because it actually rings and provides a visual square around the lesion that is being questioned as you're doing the colonoscopy. Interestingly, with all these false positives, because it's continuous, if you have a little bit of stool, even a little bit of a bubble, if you go ahead and suction and have a suction artifact, these will all lead to false positives, activations that you in your brain have already ruled out. And this actually increases the total time span of about less than 1 minute for 30 to 60 false positive activations per colonoscopy. But that's one of the problems. Another would be where you're using the AI, and I actually started using an AI solution 2 weeks before I came out here. And in fact, you can see that you try and compete with the AI. You say, oh, would I have seen this? Would I have not seen this? Is the AI true or not? And this it actually prolongs the time of the colonoscopy. And this supposedly takes several months to get used to as well. So be aware of it. There are operational issues. If we have time, and if you want to, I'll try and show there's a video from a recent study from the literature. I can try and show it to you if we have time. I think it's not as pertinent to what we're discussing, I think, today. With regards to a couple of other examples before I finish, esophageal cancer in Barrett's esophagus, a meta-analysis showing that although the data are encouraging, the differences were not significant and more studies are needed. So it's an area where the prediction is good, but the prediction is not that dramatic. There was not that you actually, it is better to use than not to use this AI solution for Barrett's esophagus and predicting esophageal cancer. So just be aware of that. There's also a meta-analysis in looking at esophageal diseases in general. And here too, again, this looked at all the published data on AI's solutions in using to make a diagnosis of Barrett's. and then Barrett's neoplasia, and then to rule out esophageal squamous cell cancer. And in none of those were the comparisons statistically significantly greater. In all cases, they were comparable to endoscopists. A video capsule, for those of you who do a video capsule, there are a number of deep learning models that have been developed that look at not only tumor polyp detection, it can actually label the vascular lesions, detect celiac disease, Crohn's disease, and so on, but it also importantly minimizes by more than 90% the actual reading time of the video capsule study. So there are a lot more, but I don't have time to discuss them for you today, and I'm not familiar with all of them, but publications have touched upon other areas of GI endoscopy. They include AI-assisted assessment of completeness of mucosa. This is absolutely key. I think this is the deal breaker. We cannot detect polyps if we don't see the mucosa in which the polyp is growing. They now have AI solutions that can give you a percentage estimate of the total mucosa that you have seen during your colonoscopy examination. I eagerly await this particular AI solution. There are a couple being developed. There are others looking at grading of disease in IBD, level of cleansing in colonoscopy, for example, using the Bell Prep score, the Harvard Prep score, looking at natural language processing software, predicting adverse events due to sedation, looking at and predicting accurate post-polypectomy surveillance, and finally diagnosing serrated polyposis syndrome. So these are some examples. So how can you tell that this is a good study? This, if you're going to pick up something from the literature, this is what you want to look at. Assess the prediction task. Is there clinical utility to having this prediction? Does the model show better screening, improved efficiency, faster or more accurate diagnosis, or accurate prediction of prognosis? Assess the data. The format of the input that the data that was used to train the model. Was it labeled and annotated? Did it use an expert group that thought it was the right thing, or were they using consensus grading of a given evaluation definition? Patient populations, are they heterogeneous or were they limited? Meaning, are they generalizable or not? Were there a lot of data or just a few data that were used to train the model? And finally, the splitting between the training and the testing set. Assessing the machine learning method, this obviously we're not experts at it, but is an established method, or did they do some weird method that's not usually used? Training process, cross-validation, testing, and the time taken to perform the prediction tasks. And finally, assessing the model performance. This is perhaps key as clinicians. Is it relevant for us? Does the accuracy equate to clinical efficacy? Is it independent of external validation? Are there human comparisons, meaning compared to operators, potential confounding variables? Is it repeatable and reproducible and generalizable to the patient population you're looking at? So these are tools that we now do when you have, for example, randomized trials that you need to apply, particularly the fourth on the right. The others are relatively new and you should be aware of them. So what is next? I would mention to you, I have a complicated graph, but I suggest in this year's gastroenterology in the last 3 months, the Messman has published an algorithm suggesting where in different areas the AI solutions may fall into place in improving clinical practice. It was a complicated graph and I don't have time to go over it with you, but I suggest you have a look at that and I'm happy to share it with you. I have an additional slide if you want it during the discussion section. So AI is here to stay in clinical medicine. It will expand possibilities. Try and get familiar with some of the basic AI principles, and I hope I didn't put you to sleep by going over all of the terminology and some of the methodology, but I think it's absolutely key. If not, this remains a black box, and you're not going to want to look and read the studies and understand their relevance to your clinical practice. Multidisciplinary expertise is absolutely required in completing clinically pertinent AI studies. Be cautious about interpreting AI study results. Think of it as black box situation. Make sure that what they say is deliverable, has clinical pertinence to what you're looking at. There are needs for society-driven quality reporting, which really have not been well developed, as well as for reporting in the medical journals, which has not been well developed. And finally, there will be local issues relating to research and implementation of AI solutions that will be critical. And you need to be aware of this at the institution where you work, in the university, in the province, in the country that you work in. I think I'll stop there. I thank you very much for your attention, and I'll be happy to answer questions as you have.
Thank you, Professor Barkun, for the informative presentation. Maybe we can allow for one question, for any questions from the audience. Any questions to Professor? No questions? Okay, Professor, thank you so much for
All right.
being with us tonight. I wish it was in Riyadh physically, but inshallah, in
do
the
I.
future, we'll see you again. And
Thank you.
just to convey the greetings of Professor Al-Madi. He couldn't make it also tonight, but this is just a message from him to you. Thank
Very
you so
good.
much.
Thank you.
again, and inshallah, we'll see
Thank you very
again.
much. And I wish you luck in using AI solutions in your practices. Thank you and bye-bye.
Thank you. Thank you. I think now we can.